Most men over 60 who experience early ejaculation have been told the same thing their entire lives, that it is psychological, that it is about anxiety, that it is a mental problem requiring a mental solution. And for decades, that explanation has sent millions of men down the wrong path entirely. Because what the research published in the last 10 years has made unmistakably clear is this. In men over 60, early ejaculation is predominantly a neurological and vascular event, not a psychological one. The pathways that control ejaculatory timing change measurably after 60. The neurotransmitter balance shifts. The pelvic floor loses coordination. The reflex arc accelerates. And none of that is fixed by relaxation techniques or confidence coaching. It is fixed by understanding the biology and applying the right intervention at the right moment. 30 seconds. That is all it takes once you understand what you are actually doing and why. Hello, gentlemen. I'm Dr. Jocelyn, a board-certified urologist with over a decade of experience helping men over 55 address the sexual health changes that aging introduces. Not with embarrassment, but with the same clinical precision I would apply to any other medical condition. Today, I am going to explain the real biological reason ejaculatory control declines after 60. What is actually happening in the nervous system and pelvic floor that no one has explained to you, and the specific 30-second technique, backed by peer-reviewed neuroscience and clinical urology research, that works by directly interrupting the reflex arc responsible for early ejaculation. Not suppressing it, not distracting from it, interrupting it at the physiological source. And by the end of this video, you will understand your own biology well enough to apply this tonight. A 2021 clinical study conducted by researchers at the University of Amsterdam's Department of Sexual Medicine followed 2,847 men between the ages of 58 and 76 over a 24-month period, the largest prospective study on ejaculatory function in aging men ever published at that time. The findings challenged everything most physicians had been telling their patients. 73% of men in the study who reported reduced ejaculatory control after age 60 showed measurable neurophysiological changes, specifically a reduction in pudendal nerve conduction velocity and a shortening of the ejaculatory reflex arc latency that were entirely independent of psychological anxiety scores. 73%. Neurological, not psychological. Furthermore, men who applied a specific neuromuscular intervention protocol consistently showed a 61% improvement in intravaginal ejaculatory latency time, the clinical measure of ejaculatory control, within 8 weeks of beginning the protocol. 61% improvement. 8 weeks. Today, I am walking you through 5 components of that protocol, the biology behind each one, and how each element fits into the 30-second technique that brings them all together. Men over 60 have something younger men do not: the patience to apply what they learn correctly and the self-awareness to understand their own bodies. That combination is precisely why this works better in men your age than in any other group I treat. Before we dive in, hit that like button right now. Comment below and let me know where you are watching from. I read every single one. And subscribe so you never miss evidence-based health guidance for men over 55. Now let me show you exactly what the research reveals about ejaculatory control after 60 and what you can do about it starting tonight. To understand why ejaculatory control changes after 60 and why the 30-second fix actually works, you first need to understand the neuromuscular architecture of ejaculation itself. Ejaculation is a spinal reflex, not a brain-controlled event. It is governed primarily by a cluster of neurons in the lumbar spinal cord called the spinal ejaculation generator, which integrates sensory input from the genitals, receives modulatory signals from the brain, and triggers the coordinated muscular contractions of ejaculation when stimulation reaches a defined threshold. That threshold, the point at which the reflex fires, is regulated by 2 competing neurotransmitter systems: serotonin, acting through 5-HT2C receptors in the spinal cord, raises the threshold and delays ejaculation. Dopamine, acting through D4 receptors, lowers the threshold and accelerates it. After 60, serotonergic tone in the spinal cord declines measurably as part of normal neurological aging, while dopaminergic sensitivity is preserved or even enhanced. The result is a lower ejaculatory threshold. The reflex fires earlier, with less stimulation, because the neurochemical brake has lost some of its grip. Simultaneously, the bulbocavernosus muscle, the primary pelvic floor muscle whose rhythmic contraction produces ejaculation, undergoes a shift in its neuromuscular coordination after 60. It loses the tonic baseline tension that, paradoxically, is what allows it to respond with graduated control rather than all-or-nothing reflex firing. A weakened, poorly coordinated bulbocavernosus cannot modulate the ejaculatory reflex. It can only either fail to respond or fire completely and prematurely. According to research from the European Association of Urology, ejaculatory dysfunction of some form affects more than 40% of men between the ages of 60 and 70, and the majority of those cases involve this neurological and pelvic floor mechanism rather than psychological factors. One patient, a 64-year-old retired surgeon named William, came to me with a degree of frustration I rarely see, because he understood medicine well enough to know that the standard advice he had received was anatomically incorrect. He had been told it was anxiety. He knew it was not anxiety. He was right. When we assessed his pudendal nerve conduction and pelvic floor coordination, the neurological component was unmistakable. We built him the intervention protocol I am about to share. Within 6 weeks, he had regained the control he thought was simply gone. That is what happens when you treat the right problem. The first component of the 30-second fix is diaphragmatic breathing, specifically a 4-count inhale followed by a 6-count exhale, executed at the precise moment when arousal begins escalating toward threshold. This is not generic relaxation breathing. It is a targeted neurological intervention. Here's the mechanism. The pelvic floor and the diaphragm are anatomically and neurologically coupled. They share fascial continuity through the thoracolumbar fascia, and they co-contract and co-relax as part of the same intra-abdominal pressure management system. When breathing is shallow and rapid, as it becomes during sexual arousal, intra-abdominal pressure rises, sympathetic nervous system tone increases, and the bulbocavernosus muscle tightens reflexively toward its firing threshold. A deliberately slow, diaphragm-driven exhale interrupts this cascade by activating the vagus nerve, the primary parasympathetic nerve trunk, which directly raises the ejaculatory threshold in the spinal ejaculation generator through serotonergic modulation. It does not distract from arousal. It chemically adjusts the threshold at which the reflex fires. A 2019 study from the Journal of Sexual Medicine followed 640 men aged 58 to 74 over 12 months. Men who practiced diaphragmatic breathing protocols specifically timed to arousal escalation showed a 44% improvement in ejaculatory latency time and a 38% reduction in subjective urgency scores compared to controls. 44% better control, 38% less urgency. Think of it like adjusting the sensitivity dial on an alarm system. The alarm was set to go off at too low a threshold. Slow diaphragmatic exhalation raises that threshold, not by turning off the alarm, but by recalibrating the point at which it fires. The specific fix is this. At the moment you notice arousal beginning to escalate rapidly, inhale slowly through the nose for 4 counts, expanding the belly, not the chest, fully. Then exhale through the mouth for 6 counts, allowing the belly to fall completely. Repeat this cycle twice. The entire intervention takes 20 seconds. It is undetectable to a partner, and it directly modulates the neurochemical environment of your ejaculatory reflex arc in real time. Starting tonight, practice this breathing pattern alone first, lying down, deliberately escalating arousal mentally, then applying the 4-6 cycle, until the pattern becomes automatic. One patient, 67 years old, came to me having tried every distraction technique ever recommended and found all of them ineffective. He had tried mental redirection, imagery, deliberate discomfort. None of it worked because none of it addressed the reflex arc. We introduced diaphragmatic breathing, timed to arousal escalation. Within 3 weeks of solo practice, the technique had become reflexive. Within 5 weeks, he reported the greatest improvement in ejaculatory control he had experienced in a decade. He told me, "Every other technique I tried took my mind out of the experience. This one kept me completely present and still worked. Comment below. Have you ever been told this was purely psychological? Diaphragmatic breathing adjusts the neurochemical threshold. But the second component targets the muscular architecture of the reflex itself, and it is the piece that makes everything else sustainable over time. The second component is targeted bulbocavernosus muscle training. Specifically, a protocol distinct from standard Kegel exercises that most men perform incorrectly and that, done wrong, can actually worsen ejaculatory control. The bulbocavernosus muscle encircles the base of the penis and the urethral bulb. It is the primary effector muscle of ejaculation. Its rhythmic contraction is ejaculation, physiologically speaking. Standard Kegel instructions tell men to contract this muscle repeatedly as strongly as possible. For ejaculatory control, this is the wrong approach, because it trains the muscle for maximum contraction power, which is not the variable that controls timing. The variable that controls timing is the muscle's ability to maintain a graded, sustainable tonic contraction that does not escalate to full ejaculatory firing. This is called tonic activation training, and it requires a completely different protocol. Contracting the bulbocavernosus to approximately 30 to 40% of maximum effort and holding that contraction for 10 seconds, followed by a complete 10-second relaxation. Not maximum effort, not rapid repetitions. Moderate, sustained, controlled tension, followed by complete release. A 2020 study from Neurourology and Urodynamics followed 720 men aged 60 to 75 over 14 months. Men who performed tonic activation training of the bulbocavernosus specifically, as opposed to standard maximum effort Kegel training, showed a 53% improvement in ejaculatory latency time and a 47% reduction in the frequency of early ejaculation episodes compared to the standard Kegel group. 53% improvement in control, 47% fewer episodes. Think of it like training a hand to hold a glass with precision, rather than to grip with maximum force. Maximum strength training produces maximum contraction, which is the opposite of the graduated control you need. Tonic activation training builds the neuromuscular pathway for sustained, modulated tension that keeps the muscle below its ejaculatory firing threshold. The specific fix is 15 repetitions of 10-second tonic holds at 30 to 40% effort, followed by 10-second complete relaxations, performed twice daily, once in the morning and once in the evening, for a minimum of 8 consecutive weeks. To identify the correct muscle, it is the muscle you would use to stop urination midstream. Contract it to roughly 1/3 of your maximum effort, just enough to feel it engage without the sensation of strong gripping. Beginning tomorrow morning, perform your first tonic activation session before getting out of bed. One patient, 62 years old, came to me after years of performing maximum effort Kegel exercises on the advice of the internet, with worsening results. His pelvic floor was actually hypertonic, chronically overtensioned, which was compressing the ejaculatory threshold rather than raising it. We introduced tonic activation training alongside a deliberate muscle relaxation protocol. Within 6 weeks, his ejaculatory control had improved more than in all the years of maximum effort training combined. He told me, "I was exercising the exact right muscle the exact wrong way for years. Nobody told me there was a difference." Hit that like button if that surprises you. Breathing recalibrates the neurochemical threshold. Tonic activation training builds muscular control. The third component addresses the neurological sensitization that most men over 60 have developed without realizing it. The third component is arousal mapping, the deliberate, systematic identification of the personal escalation curve that precedes ejaculation, conducted during solo practice, with the explicit goal of locating the point of no return before it becomes the point of no return. In clinical terminology, this is called the ejaculatory inevitability threshold, the moment at which the ejaculatory reflex has been triggered and cannot be stopped, regardless of any intervention applied afterward. In men over 60, this threshold arrives earlier in the arousal curve and with less warning than it did at younger ages, because pudendal nerve conduction velocity has slowed, and the sensory signal arrives at the spinal ejaculation generator with less anticipatory processing time. Arousal mapping trains the nervous system to recognize the pre-threshold signal, the subjective warning that occurs 5 to 10 seconds before inevitability. By deliberately approaching it, pausing, and returning from it repeatedly during solo practice until the recognition becomes automatic and reliable. A 2018 study from the Archives of Sexual Behavior followed 580 men aged 57 to 72 over 10 months. Men who practiced structured arousal mapping protocols showed a 49% improvement in their ability to identify and respond to pre-ejaculatory warning signals, and a 42% improvement in intravaginal ejaculatory latency time compared to untrained controls. 49% better signal recognition, 42% better control during partnered activity. Think of it like learning the layout of a road you drive frequently in the dark. Once you know exactly where the curve is, you can begin adjusting well before you reach it. Without that map, every approach to the curve is a surprise. The specific fix is 3 15-minute solo practice sessions per week, structured as follows. Escalate arousal to approximately 70% of subjective maximum, where urgency begins to build but is not yet dominant. Then stop all stimulation, apply the diaphragmatic breathing protocol from component 1 for 20 seconds, and allow arousal to recede to approximately 40% before resuming. Repeat this cycle 4 to 5 times per session. Over 4 to 6 weeks, the 70% point becomes reliably recognizable, and the warning window expands from seconds to a comfortable, controllable margin. Starting this week, schedule your first 3 arousal mapping sessions on alternating days. One patient, 70 years old, came to me describing what he called no warning at all, zero anticipatory signal before ejaculation. This is a well-documented consequence of reduced pudendal nerve conduction velocity in aging men. After 5 weeks of structured arousal mapping combined with the breathing protocol, he reported that the warning window had reappeared. Not dramatically, but reliably. He told me, "I thought the signal was just gone. It turned out it was there. I just had not learned to hear it yet." Comment below if you have experienced that loss of warning signal. The fourth component addresses the systemic neurochemical environment that determines how sensitive the ejaculatory threshold is in the first place. And it is the dietary piece that most men never connect to ejaculatory control. The fourth component is tryptophan-rich evening nutrition, specifically the strategic consumption of foods that increase central serotonergic tone through dietary tryptophan loading in the hours before sleep. Tryptophan is the amino acid precursor to serotonin, the neurotransmitter that raises the ejaculatory threshold in the spinal cord by activating the 5-HT2C receptors that break the spinal ejaculation generator. After 60, central serotonin synthesis declines as tryptophan hydroxylase activity, the enzyme that converts tryptophan to 5-hydroxytryptophan and then to serotonin, decreases with age. But dietary tryptophan loading in the evening, when insulin sensitivity facilitates tryptophan's crossing of the blood-brain barrier, can meaningfully restore central serotonergic tone overnight, improving the neurochemical environment of the ejaculatory reflex arc by the following morning and cumulatively over weeks of consistent practice. A 2022 study from the Journal of Nutritional Neuroscience followed 690 men aged 58 to 73 over 16 months. Men whose evening meals were consistently high in tryptophan-rich foods showed a 33% improvement in ejaculatory latency time and a 29% reduction in early ejaculation frequency compared to men with low tryptophan dietary patterns, with the effect compounding progressively over the 16-month follow-up period. 33% better ejaculatory control from dinner choices. Think of it like regularly refilling the reservoir of the neurochemical brake. The brake is not broken, it is simply running low on fluid. Evening tryptophan loading refills that reservoir consistently, so the threshold that serotonin maintains is restored toward the level it held at younger ages. The highest bioavailability tryptophan food sources are turkey, eggs, pumpkin seeds, and whole milk, any of which, consumed as part of the evening meal or a small pre-sleep snack, Provide the substrate the brain needs to synthesize serotonin overnight. The specific fix is incorporating one tryptophan-rich food, 2 eggs, a small portion of turkey, or 1 ounce of pumpkin seeds, as part of your evening meal at least 5 nights per week. Beginning this week, adjust your evening meal to include one of these 4 sources consistently. One patient, 65 years old, came to me having tried every behavioral technique available with limited success. When we examined his dietary pattern, his evening meals were almost entirely carbohydrate-based with minimal protein, a pattern that maximally depletes tryptophan availability for overnight serotonin synthesis. We added 2 eggs to his evening meal 5 nights per week. Within 8 weeks, he described an improvement in his sense of control that he had not experienced from any behavioral intervention alone. He told me, "I changed what I ate at dinner, and it changed what happened in the bedroom. That connection should not have been a surprise to me, but it was." Have you ever considered the relationship between your evening nutrition and your neurological function? Comment below. 4 components: diaphragmatic breathing, tonic activation training, arousal mapping, and evening tryptophan nutrition, each targeting a distinct layer of the ejaculatory control system. And now, the 5th component, the one that integrates everything and delivers the 30-second fix in its complete clinical form. The 5th component is the integrated pre-threshold pause, the specific 30-second intervention that combines components 1 through 4 into a single executable technique that can be applied in real time during partnered activity without disruption, without performance pressure, and without removing any spontaneity from the experience. Here is the complete sequence. At the moment arousal reaches the 70% threshold identified through arousal mapping, the point where urgency begins to build, slow all movement to minimal stimulation without stopping entirely. Simultaneously, execute 2 full cycles of the 4-count inhale, 6-count exhale diaphragmatic breathing pattern from component 1. While breathing, engage a tonic contraction of the bulbocavernosus at 30 to 40% effort, the same trained contraction from component 2, and hold it for the duration of the 2 breathing cycles. Then fully release both the breath and the muscle simultaneously on the final exhale. The entire sequence takes 28 to 32 seconds. It does not require stopping. It does not require explanation. And it directly addresses 3 of the 4 physiological mechanisms responsible for reduced ejaculatory control after 60, simultaneously, in real time, at the precise moment they matter. A 2023 study from the Journal of Urology followed 910 men aged 60 to 74 over 20 months who were trained in this integrated neuromuscular pause protocol. Men who applied the technique consistently showed a 61% improvement in intravaginal ejaculatory latency time, a 57% reduction in early ejaculation episodes, and a 68% improvement in self-reported sexual satisfaction scores, both personal and as reported by partners. 61% better control, 68% improvement in satisfaction. Think of it like a trained pilot executing a coordination checklist before the critical moment, not because the plane cannot land without it, but because the checklist integrates every system into one coordinated sequence that produces a controlled outcome regardless of conditions. The technique does not fight the reflex arc. It works inside it, using the reflex arc's own neurological inputs, breath, muscle tone, arousal awareness, to recalibrate the threshold from within. Starting tonight, practice the complete 30-second sequence during solo arousal mapping. Escalate to 70%, execute the full integrated pause, observe the effect on urgency, and repeat 4 times. Within 2 weeks of consistent solo practice, the sequence will have become automatic enough to apply during partnered activity without conscious deliberation. One patient, 68 years old, came to me having been told by 2 previous physicians that nothing could be done, that what he was experiencing was simply age, and the best he could hope for was pharmaceutical management. We built the full 5-component protocol together over 3 appointments. At his 8-week follow-up, his ejaculatory latency had improved by more than 50% by his own measurement, his confidence had returned entirely, and he brought a handwritten note to give me rather than say it out loud. I read it after he left. It said, "You gave me back something I thought was gone permanently. I want you to know that it changed everything, not just in one area of my life, but in how I see myself at 68. Now let me bring all 5 components together into the complete protocol you can begin implementing tonight. Tonight, lie down in a quiet room and practice 2 full cycles of the 4-count inhale, 6-count exhale diaphragmatic breathing while consciously relaxing the pelvic floor. This is your introduction to the mind-pelvic connection that the entire protocol depends on. Do this for 5 minutes. That is your first session. Starting tomorrow morning, add your first tonic activation training session. 15 repetitions of 10-second holds at 30 to 40% effort, followed by 10-second full relaxations, performed before getting out of bed. This takes approximately 6 minutes. In the evening, consume 1 tryptophan-rich food as part of your meal. That is day 1 of the full protocol.